Morning, ladies and gentlemen. We're now sitting in public. Proceedings are being broadcast. And before we begin, can I remind members to switch off electronic devices, please? This morning we're going to hear from 3 witnesses, all of whom are joining us from Australia online, where it is either early or late evening. The first is Dr. Greg Mewett, who is a specialist palliative care physician. The second is Dr. Clare Fellingham, Deputy Director of Medical Services for Royal Perth Hospital in Western Australia, and Dr. Cam McLaren, who is an Australia and New Zealand oncologist. Before calling the first member in question, I'd like to ask members to keep questions as short as possible, please, because we've got a very limited amount of time. We have for this session until 10:25. And just for the sake of the sound check again, could I ask first Dr. Mewett if you'd be kind enough to introduce yourself and make a very brief opening comment. Dr. Mewett. That's a good start. We're on mute.
My fault.
Thank you.
I'm Greg Mewett. I'm a palliative care physician of many years standing. I live in central Victoria, Ballarat, in Victoria. I've been involved as a palliative care physician over many years and became involved in the Voluntary Assisted Dying Implementation Task Force, which was charged with the task of bringing the enactment of legislation into practice. I've subsequently incorporated voluntary assisted dying into my specialist palliative care practice, and more recently have been appointed as a member of the Voluntary Assisted Dying Review Board in Victoria.
Dr.
I'm
Fellingham.
here to assist the members.
Sorry, I beg your pardon.
I'm just here to assist in whatever way the committee members feel we can help.
Committee is deeply grateful to you. Dr. Fellingham.
Thank you. My name is Dr. Clare Fellingham. I'm originally from the UK. I now live and work in Western Australia as a consultant anaesthetist. I've also got a clinical fellowship in palliative care, and I'm due to complete a Master of Bioethics this year, so the study of applied ethics, and I chair our regional clinical ethical committee. I led the clinical leadership at the implementation of voluntary assisted dying across my health service in 2021, and then became a voluntary assisted dying practitioner. I've been a high volume practitioner for 2 years, and then I've recently scaled that back to work more in the with VAD Australia and New Zealand, which is the peak body that Dr. Cam McLaren set up to try and represent and promote assisted dying throughout Australia and New Zealand. And I also would like to contribute anything that I can from a multifaceted position, but with lots of lived experience in this space, and to really begin by stressing to the committee that the law you're proposing only applies to people who are terminally ill. It's exactly the same as the laws that apply across Australia and New Zealand, and very unlike the more permissive models that exist in Europe and Canada. And it's so important to keep that in sharp focus, that we're talking about giving dying people that don't have a choice, but it's not a choice between...
I'm sure we'll come back to that. I'm sure we'll come back to that. Dr. McLaren.
Thank you, Chair. So I'm Dr. Cam McLaren. I'm a medical oncologist, an early adopter of voluntary assisted dying. I was not involved with the campaigning for voluntary assisted dying. On the eve of the introduction of voluntary assisted dying in Victoria, I did the training thinking that it was just an extension or the next step in patient-centred care, as this was a patient-led adjustment in our legislation. In Victoria, our law requires a specialist in the area of disease that the patient has to be one of the 2 assessing doctors. And due to the low uptake amongst my peers, I became quite exposed to this. I have been involved in over 300 cases of application for voluntary assisted dying, and through that experience have contributed to the development and implementation of voluntary assisted dying laws in other states of Australia, also New Zealand, and spoken across in the Isle of Man and at the World Cancer Congress in Switzerland. I'm the founder of Voluntary Assisted Dying Australia and New Zealand, where I saw a space to improve the quality and safety of provision of voluntary assisted dying care from a provider perspective. Thank you very much for having me.
Thank you. Colleagues will have noticed there's a slight delay on the line. Please take account of it when you're asking questions. And briefly, please, Sarah Green.
I'm keen to hear about the training, education and clinical supervision you have in place for assisted dying. Perhaps I'll address that to Dr. Fellingham, but I'm sure all of you could probably answer that question.
Thank you. Certainly. So the training is very stringently developed and very, very rigorously tested. So our mandatory training package that is required by all doctors who want to practice assisted dying was developed by our colleagues in the Australian Centre for Health Law Research at the Queensland University of Technology. And it drew on extensive research that group have conducted from around the world to create an online training package which takes at least a day to complete and covers a huge amount of things that are of great concern, not unsurprisingly, things like how to assess capacity, how to detect coercion, how to assess for voluntariness, and how to determine the various different eligibility criteria that apply here in our Western Australian law. To be able to access that training, so to become a voluntary assisted dying practitioner, a person already has to be a doctor of quite some standing in their own specialty. So you have to be a consultant in a specialty with at least 1 year of full-time practice under your belt, or a general practitioner with at least 10 years of broad experience. So we're not talking about junior doctors being able to offer this, we're talking about doctors of significant clinical standing with a very, very broad range of patient experiences. Once they put themselves forward, they do that training, and then within all of, and that training has to be refreshed and updated. For us, it's every 3 years. Then when you work within a health service, so I have 5 hospitals in my health network, and I, together with my colleagues, developed a very comprehensive package of training, education and awareness, which is tailored at the various different levels of people who might have a role in this, from a nurse on the ward all the way through to someone who's actually actively taking part in the process. And there are also a very, very wide range of documents and training packages that have been developed by our Department of Health. In addition to that, all practitioners who work in this space are invited to become members of our community of practice, where we share peer education and experiences and have guest speakers from national and international viewpoints to help to continue to educate us as a group to ensure our practice is consistent and in line with local and international standards.
Thank you.
Do either of the other witnesses want to come in on that before we come back to Sarah Green? No? Mr. McLaren?
I think, if I might add, I think this, when we started this in Victoria, we did see a bit of a gap here with the implementation. I think a lot of the education was surrounding the legalities of providing a assessment service in a way that was conformed with the legislation rather than focused on the clinical skills and application. So I'm quite proud of the role that we've had in rolling that out and providing that peer experience and focusing more on some of those clinical skills to apply within a VAD context.
Sarah Green? No, thank you. Nasha?
Thank you, Chair. A couple of questions. Dr. Fellingham first. Victoria is quite a rural state, and I can imagine there are difficulties reaching all parts of it. Am I right in thinking that the statewide pharmacy service, which delivers assisted dying drugs across the whole state, has been set up, but there is no comparable service for the delivery of pain reduction?
Dr. Fellingham?
So just a point of clarification, I work in Western Australia rather than Victoria, but I can give you a view for Western Australia, which is significantly larger, and so the problem that you've alluded to is much more complicated. If you'd like me to speak in a Western Australian context?
It would be, well, I was talking about Southern Australia in particular, but that's fine, we can move on. Thank you. The Australian British media...
I can speak to the Victorian question if you prefer.
Yeah, Cam or Greg could speak to that.
Dr. McLaren?
So to answer your question, we do have a statewide service that supplies the medication across the state. Medication for pain relief is available through standard pharmacy access, so there's no barriers to accessing medication for palliative purposes in rural Australia. It's actually quite hard to get a voluntary assisted dying medication dispensed to Mildura, which is many hours away from the single state pharmacy, so the access is actually more difficult for voluntary assisted dying than it is for palliative medications.
Thank you. The Australian British media reported the tragic story of Cyril Toos, an elderly and terminally ill 84-year-old man, again in southern Australia, who requested voluntary assisted dying. Mr. Toos stated that he was applying for voluntary assisted dying after waiting nearly a year for the state government to implement a care and housing package for him. He died whilst waiting for the application process to end. How much do social detriments influence requests for voluntary assisted dying? And please, can you speak from your own experience and published data?
Well,
anyone who can speak to it.
Dr. Mewett, come in.
So, yes, from a palliative care perspective, like Cam, I've been involved, and Clare, I've been involved in the assessment and discussions with many patients who have requested assisted dying. These patients come from a whole range of socioeconomic backgrounds. In fact, if anything, they tend to come from a perhaps slightly higher, more well-educated background. There is no evidence in our jurisdiction in Victoria, where we've had 5.5 years experience, that there's any suggestion that people who are underprivileged or less educated or in some way other vulnerable have readier access or apply more for VAD. The case you're alluding to, like many cases that are often reported from Canada, are certainly tragic in their own way, but are in absolute minority when compared to patients who genuinely are determined to have a choice in the way and when they die. These are separate issues. One's a social welfare issue, the other one is a VAD issue. A patient such as that would not be found eligible unless he was eligible under the strict criteria that apply in the state in which he lived.
Dr. McLaren.
I think Greg touched on it there. Certainly it was that this gentleman may have applied for voluntary assisted dying, with that being one of his drivers, but it certainly wouldn't have made him eligible. He did not access voluntary assisted dying, so the system worked. And we do see higher socioeconomic status patients applying for voluntary assisted dying. That's evidenced in our voluntary assisted dying review board reports that show a greater proportion of people with higher levels of education. That data is freely available through the Victorian Government website.
And Dr. Fellingham, you had your hand up.
Yes, I then looked up, the Minister asked for some evidence. So our voluntary assisted dying board reports from Western Australia are also freely available, publicly searchable documents. And I can tell you that we ask each year, or the board asks each year, the patient's reasons for accessing voluntary assisted dying. And in order of commonality, the only ones over 50% are loss of dignity or concern about it, loss of autonomy or concern about it, or less able to engage in activities making life enjoyable or concerned about it. And so what that reflects to me is that the type of people who seek access to assisted dying are people who do tend to be, as my other colleagues have mentioned, more health literate and more socioeconomically advantaged than your average healthcare consumer, and people for whom the existential reasons that upset them about their disease process are the primary drivers for them seeking access to voluntary assisted dying. It's very rarely in the absence of service provision or because they feel that they don't have any other choice.
Thank you. Mary Tibble, please.
Thank you. Just looking ahead to our next panel, are you aware of any serious concerns being expressed by disabled people about the Australian assisted dying laws and any risks they might pose to this group? And it would be very helpful to hear from you if there are any recommendations you can make with regards to building in safeguards for the law that we are scrutinising at this stage. Thank you. And I'd be grateful to hear the reflections from all three of you on that issue.
Dr. McLaren.
So in discussion with, or throughout the voluntary assisted dying legislative process in the other states that I've been involved in across the rollout throughout Australia, the main concern that has come from disability organisations is that they agree that, or that they don't want to be found eligible for the sole reason of their disability, which is involved in all of our legislations, that people are not eligible purely on the basis of that. But they also voice a very strong concern that they don't want to be found ineligible based on their disability either. They would like to have access to this in the event that they do have a disability, but then also develop a terminal illness. So that's been a very strong voice throughout all of the debates in Australia and New Zealand.
Dr. Fellingham.
Oh, it was Dr. Mewett. Sorry. I just wanted to reiterate that on our implementation task force in Victoria, of the 13 of us who are representing of various people, we had one very strong disability advocate who served on that implementation task force and was a strong voice in ensuring that the laws were not discriminatory in any way against patients who have any degree of disability. And I would always indicate this is a voluntary assisted dying program. The word voluntary is not used often enough in this space.
Dr. Fellingham, do you wish to add to that?
Thank you. Just briefly to go back to the point that I was making just in my introduction, that it's extremely important to keep in very sharp focus that the law that you're proposing to legislate in the UK is similar to the laws that exist in Australia, New Zealand and most of the laws in the United States, that they only apply to people who are terminally ill, and therefore people who only have a primary disability, a primary mental health condition, a primary dementing condition or a non-terminal condition such as anorexia or a whole host of other conditions that are found eligible in the more permissive laws simply wouldn't actually be able to be found eligible. And it's really, really important that we keep that in very sharp focus, that this law is only for terminally ill people.
Mary Tidwell.
Thank you, that's extremely helpful. And we have clause 2, subsection 3, A and B, which covers the point that you make around those groups, for the avoidance of doubt, not just by those statuses being considered to be terminal. I'm very interested to hear about the implementation task force. I'm personally keen that we monitor, if this bill passes at the final stage into law, that we monitor the impact on disabled people on an ongoing basis, and wonder if there are any recommendations that you could make about how we can assure that they have a strong voice in that process, to keep that in check and to understand the impact on, if any, the culture within the NHS and other services.
Dr. Mewett.
Only in as much that if there is an implementation task force, and most legislation requires an implementation period, in our case it was 18 months, that someone with a strong disability advocacy is involved in that task force.
Dr. McLaren.
If I may, just to plant the seed of funding for research throughout your implementation and early stages of voluntary assisted dying, I think conducting particularly qualitative research in this area would be very revealing to understand not only everyone's reasons for applying to voluntary assisted dying, but also some marginalised groups, and whether there are any other factors influencing their decisions. I think that also extends to research conducted in culturally and linguistically diverse populations. We have a concern that health awareness, particularly through what we affectionately call our gag clause, where our medical practitioners are not able to initiate conversations with our patients about voluntary assisted dying, that unfairly disadvantages people from culturally and linguistically diverse populations, and also those who have lower levels of health literacy from accessing information about care that is available to them and what their health options are. We feel that comes mainly from discussions with general practitioners, and not allowing those general practitioners to discuss those options with them it certainly doesn't do them any favours.
Thank you.
Fellingham.
I think both my colleagues have made excellent points that I was going to make as well. I think they've covered it very well.
Just want to make sure that you didn't have anything you wish to add. David Francis.
Thanks, Chair. So yesterday we heard from some clinicians from the USA who outlined how they've reviewed the scheme in practice. And in that summary, they outlined that their waiting period between two clinician appointments has been reduced from 14 days to 48 hours, and also that the second clinician has been removed and replaced instead by a nurse practitioner in some cases. So I just wanted to understand if you've undertaken a similar review and if you've made any changes as a result.
Sorry, Chair, I didn't hear you. I might just start speaking if that's all right with you. Certainly, we've had our, or we're undergoing our review at the moment that was meant to commence after the first 5 years of operation of the Voluntary Assisted Dying Act in Victoria. That review has yet to be tabled or published. Certainly, the recommendations that we have submitted to it involve reducing or removing the so-called grace period or waiting period involved in these. It's certainly my experience and that of almost homogenous group of practitioners that patients serve their own lockout periods and grace periods and periods of reflection, I believe you've called them, before applying for this. And then subsequent to that is that there are several logistical pauses throughout the process that instigate their own grace periods as well. So the addition of further periods for reflection, I think, is superfluous and unnecessary. Secondary to that, in our all of our bills and our acts, we have an ability to bypass those waiting periods. And I did note, forgive me if I'm wrong, but I did not see the capability to bypass any of those in your current bill. If the person has a prognosis of less than 7 days, they should be able to be expedited and not serve that time. So I don't see the purpose of putting extra time on these people to apply for this. I think another point I'd like to make is that people don't. I always say that people don't know that they have 6 months to live until they have 6 weeks to live, and we as oncologists don't know that either. In the matter of one CT scan, we can change a person's prognosis from 18 months to 3 months, and all of a sudden they start thinking about how their life would, or how they see their life ending, and then they have to engage in a process of application that might take a month to apply out of that 3-month period. So I would, my recommendation has always been to increase the prognostic eligibility criteria from 6 months to 12 months to remove waiting periods that patients will place on themselves regardless of the legislative requirements.
Dr. Mewett, you're nodding.
Yes, thank you. Not nodding off, you'll be pleased to know.
It's not that late yet.
No, it's not. As a member of the Victorian VAD Review Board, and I'm here as a palliative care practitioner, but just want to give you an insight. The Review Board is now, we are as a board, a statutory body under the Victorian Act. We are now in the process of finalising a number of recommendations to our Health Minister to make some adjustments to the law. And whilst I'm not at liberty to go into detail, many of those things, such as the gag clause, the waiting period, those sorts of things are really up for challenge. They've been shown not to be safeguards, but in fact impediments and barriers to equitable and compassionate access to this scheme.
Dr. Fellingham? No? David Francis?
Absolutely. So,
I'm sorry. Dr. Fellingham, do you want to come in?
I was just going to agree with Dr. Mewett there to say that they seem like a good idea, but they do tend to be more barriers than safeguards.
Can I just clarify in line with this evidence whether there's a review as well of remaining 2 clinicians in the process, because obviously we heard yesterday that isn't the case elsewhere.
Dr. Mewett.
One has to understand that there are, whilst some broad similarities, there are a number of differences in state by state and now the Australian Capital Territory's legislation. In some states of Victoria, in the ACT, they've passed legislation, although yet to come into practice, where one of the 2 assessing practitioners could be a suitably qualified nurse practitioner. In all the other states of Australia, Each of the assessing practitioners have to be medically trained, and there are various, in different states, have different requirements of that. There are also in some states the ability for suitably qualified nurse practitioners to be the administering practitioner in the case of practitioner-administered voluntary assisted dying.
Thank you very much. For the benefit of our guests, the next questioner, Stephen Kinnock, is our Health Minister. Minister.
Thank you very much, Chair, and thank you very much for your time today. A question specifically about the period between the legislation passing your Parliament and the commencement of its provisions and the implementation, in effect, of voluntary assisted dying. Could you say a little bit more about what had to be done in that period, both in terms of the institutional arrangements that needed to be put in place between the Act passing Parliament and the commencement of it, in terms of things like institutional arrangements, training, capacity building, the kind of practical measures that you needed to put in place? And was it the case that if you did that from a standing start? So in that 18-month period, you got from, in effect, having no training and no institutional setup to being ready to actually take the system forward. I'll perhaps start with Dr. Fellingham.
Dr. Fellingham.
Thank you very much. So our law was passed on the 19th of December 2019 and came into effect on the 1st of July 2021. So we ostensibly had an 18-month period, but of course something fairly dramatic in health happened in 2020. Despite that, what happened at the Department of Health level began first, which is that the Department of Health set up an implementation leadership team and gathered together specialists from all across Western Australia in various different aspects of that, and had 8 different work streams looking at the 8 different parts of the Act that they had to operationalise. So, for instance, the pharmacology, the substance, what that was going to look like, the doses, how it was going to be administered, the setup of the pharmacy and things like that. Each of those 8 different work streams worked everything out from a Department of Health level, and then approximately 6 months before the law was enacted, which on reflection was probably not long enough, but COVID was very much complicating everything at that time. But they set up a sort of working group with the clinical leads who were implemented in the various health service provider organisations. And we were then tasked with taking this sort of broad overview and turning it into a service at the point of delivery, in the understanding that we understood the nuances and the expectations of the different hospitals and the health systems that we operated in. I won't lie, it was an enormous task. I lent very heavily on our wonderful Victorian colleagues who had gone first, and I don't know what I would have done if I was the first to pave the way, but then subsequently have also been able to offer that level of assistance to each of the other states and territories that have gone after Western Australia, and then of course to the UK, Scotland and to Jersey, who I've been working with quite a lot. So there's a wonderful international collaborative sense of information sharing and wanting to get this right, learning from experience and also not reinventing the wheel. Again, just drawing reference to the fact that the vast majority of the laws that apply across the whole of Australia and New Zealand are quite similar, and similar to what you're planning on legislating for in the United Kingdom. And there is a lot of fantastic groundwork that's been laid already, and it can be done even in a challenging healthcare context like COVID or our resource limitations.
Thank you very much for that very comprehensive answer. I don't know if there's anything that our other guests would like to add to that, but that was very comprehensive.
Well,
Dr. Mewett?
Well, because I was on the very first implementation task force running blind, I probably couldn't add much more except to say that it can be done. One has to focus on the readiness of practitioners, the readiness of health services, the readiness of the population, and a whole other range of issues, including the pharmacy service. We have a statewide care navigator service, which assists patients and doctors in this space. We had to set up a lot of services and that gave us the time to do that. It was very successful, very challenging, but fortunately we didn't have COVID in our way.
Thank you.
Thank you very much indeed. Danny Kruger.
Thank you, Chair. I'm very grateful for the evidence you've been giving, and it's really, really useful. I just want to state for the record and for your information that we have here today 3 professionals from Australia, all of whom support the laws in your country. We heard yesterday from 2 American doctors who, again, are supportive of assisted suicide laws, even though in both your countries there are many doctors who oppose what's happening, and I regret we're not hearing evidence from them. But it's very helpful to have your input. Can I just ask Dr. Fellingham about I was interested in your point that, and I note your distinction between the Australian model and that in Canada and elsewhere. And you're suggesting that the reason that most people seek assisted death is, I think you call it existential reasons. It's certainly not to avoid because of an absence of care, although we do see evidence of that in many countries. Can you just expand a bit more on why you think it's so important that we have this terminally ill definition rather than recognising pain and suffering as the reason for seeking assisted dying, when I think most of the public who support a change in the law do it because they recognise that many people would naturally want to avoid pain and suffering. And we heard yesterday from people saying that actually that's the right reason and we should write that into the law. Why shouldn't we do that?
Dr. Mewett?
Sorry, it was to Dr. Fellingham.
Thank you.
Dr. Fellingham.
Thank you. It's a very good question, and I'm grateful that you've asked it. I think we absolutely have to keep front and centre that pain and suffering are primary drivers for people seeking access to relief of suffering, whether that's at the end of life or whether that's in any interaction they have with healthcare providers. I speak to you to remember that these laws apply to terminally ill people because I feel that that's a lot easier for us to understand and for us to get our head around, but it doesn't actually detract from the fact that suffering can be a feature of non-terminal illnesses, and there are people who can suffer terribly for very long periods of time. Dementia, of course, being a clear example, but one that would be incredibly challenging to legislate for at this early stage. What's interesting, I think, about the parallels you draw, pain and suffering, is that quite common the conception is that pain is suffering and suffering is pain, and that people seek access to relief of suffering at the end of life because it's physical symptoms that are the most debilitating. And of course they can be horrendous. Pain, nausea, vomiting, anorexia, there are a multitude of physical symptoms, but they're symptoms that we tend to be really quite good at treating, and that we have a whole range of medications in our palliative care spectrum that are really very good at being able to treat those physical symptoms. So it's quite rare that people prioritise those. But suffering is subjective and it's context dependent. And what suffering is to me might be completely different to you, even if we're suffering from what looks to be from the outside a completely different disease. And suffering and the distress, the thing that makes us human, the existential overlay of our own interaction with the world and how that's impacted by our disease process is an incredibly personal journey, and one that's extremely challenging to palliate and very, very distressing for patients, their families and their practitioners if we can't support people who are suffering at the end of life. Does that answer your question?
It does very helpfully. And can I just come back to you quickly then? So you point out that it's essentially a subjective experience to suffer. So it's very difficult for somebody from the outside to determine whether somebody is suffering to a certain threshold. So really it simply should be a case of people who feel that they are suffering intolerably should be eligible. Why don't you think that that's what we should have in the law?
So our law, one of our eligibility criteria in Western Australia is that a person is suffering intolerably, in a manner that they consider intolerable, that we've taken all reasonable steps to alleviate. And the important thing about suffering is that it's it's a personal experience, so it's not mine to judge as a clinician. It's mine to delicately but expertly tease out of a patient and to attempt to mitigate and to treat to the best of my ability. But yes, suffering absolutely is what the patient says it is. And these laws are designed to honour individual patients who are dying. They're not designed for us as practitioners, as clinicians looking in from the outside. They're designed to be supportive of an individual patient's illness journey, and only they can know what the experience of that is.
Dr. McLaren?
I think it's a very good question, Ms. Kruger. I think one of the distinctions here is where the point of hope is and where the point of no return may be for that suffering. If you were to say that patients or people may apply for this for self-confessed suffering in the absence of an end-of-life condition, then that does lead to questions about, well, does it apply to 21-year-old with a decompensated mood disorder that may be able to be treated and improved? So when we're talking about patients within the last 6 months of their life, that suffering is very hard to come back from in the time that's given to them. And so it is that recognition of there's a point of difference between hope for the future and a different type of hope, a hope for improvement in symptoms, a control of the situation, but not a hope for improvement physically or return to normal function or living. And I think that's a real difference between legislating purely on the basis of suffering versus suffering in the context of suffering not going to get significantly better. So that would be kind of, I think the point of that is that the line must be drawn at somewhere. We have seen patients who have been ineligible for our laws where we've found immense suffering, and that is a difficult space to navigate in its own right. But those cases are going to happen regardless of where that line is drawn, and it needs to be in a place where people are comfortable to navigate on one side or another. And that's where that clinical education comes in to the process in terms of how do we manage that best, recognise that suffering in that individual and try to make things better and walk hand in hand with our palliative care and other colleagues to try and improve symptoms for the patients who are not eligible for these laws.
Dr. Mewett?
Yes, thank you. Look, as a palliative care physician, I spend all my professional life addressing people's suffering in the context of advanced, progressing, incurable illness. And palliative care, of course, approaches that from a whole different range of angles. And I just see VAD, assisted dying, voluntary, as an end-of-life choice amongst a number of other end-of-life choices people may or may not make. A minority of our patients will take that choice and have some control. They require and should have good palliative, excellent palliative care up until the time that they die, whichever way they decide to die. And I think we should understand that despite the best palliative care in the world, there are still patients who suffer uncontrollably and unremittingly and intolerably. And I believe it's that small minority of patients who should have a legal option to take control at that stage where it's irreparable. So it's not incompatible with palliative care. It's part of palliative care. It's an end-of-life choice, not the philosophy of care that palliative care is.
Thank you very much. Colleagues, I'm going to have to confine members to one question each from now on if we're going to try and get everybody in. And panel, if you could be kind and without denying us the information that we need, keep your answers as brief as possible. Simon Ofer.
I just wanted to very briefly for you to run through the patient pathway here. Where does the patient first arrive in the healthcare setting? Who are the two doctors? And indeed, who provides the provision of assistance at the end of life? So just a very brief sort of run through, please.
Chair, I can speak to that one if you like.
Thank you, that would be fine.
Again, each of our states and territory and Australian Capital Territory have different legislation and therefore different processes, but in broad speaking terms, say for example in Victoria a patient will express their wish to engage in voluntary assisted dying. independently. Often they are connected to the statewide patient navigator service, who will connect them with a coordinating or a doctor to receive that patient's first request and become their coordinating medical practitioner. That doctor will then conduct their coordinating assessment, determine if they believe they're eligible or ineligible, and then if they are eligible, they will refer them on to a consulting doctor or a doctor to act as a consulting doctor and to conduct a consulting assessment. If that process is also approved, then that patient is found eligible, and then they meet again with the coordinating medical practitioner to then make a written application to engage in voluntary assisted dying. That process then goes to our review board to ensure that it's compliant with the legislation before we can apply for a permit to prescribe the medication. Now, permits are our state specific. Many other states, such as Dr. Fellingham's, don't require a specific permit for individual prescription. That permit will come back within 3 days, and then we write a prescription that goes to our centralised pharmacy service, who will then wait for the patient or the contact person to then contact the pharmacy and organise delivery or dispensing of the medication. In the case of self-administration oral medication in Victoria, that medication will be dispensed to the patient, and then that's their property. They may use it immediately or never use it. It's completely up to them. They do not require medical attendance at that time, although I've provided that on many occasions and sat with patients and their families as that patient has taken their medication and died. If the medication is not used, the contact person who is nominated by the patient is legally required to return the medication to the pharmacy. If the patient is unable to ingest or digest an oral medication, we can apply for a practitioner administration, which I do believe doesn't exist in your current bill as well. And so this is authorises a practitioner, the coordinating medical practitioner, to administer the medication either via PEG tube feeding or other means intravenous to the patient to bring about their death. And I've certainly done that. I don't keep count, but I've engaged in that many a time.
Can I just
I'm
confirm?
sorry, I did say one question per person. We've got to stick to the time. Dr. Mewett, do you want to come in? Otherwise, I'll move on. Jack Abbott, please.
No, that was a very...
Jack Abbott.
Thank you. My question is for Dr. Fellingham. I'm just kind of focusing on your experiences of both the British and Australian healthcare systems, and whether you believe there's any kind of fundamental differences which would impact how assisted dying is implemented in this country, and how we might be able to mitigate some of those kind of differences in kind of your experiences of both systems.
Oh, thank you. I think in the UK you're missing a number of the challenges that we have, such as the geographical challenges, with a state as vast as Western Australia. And you also have a golden opportunity to look as you are across, every jurisdiction that already has laws in operation, and cherry pick the very best bits of what's working well in those jurisdictions to create the very, very best, most robust, but also most patient-centred legislation that you can. The healthcare systems are broadly similar. I think we're both, we're both first world developed Western countries, but still operating in a context of resource limitation, but not resource limitation that is so prohibitive that it would make it particularly difficult to enact a law in the UK. I think it would be broadly able to follow any of the laws that exist in Australia and implement them very, very successfully in the United Kingdom.
Kim Leadbeater as the promoter of the bill.
Thank you, Chair, and thank you to you all for joining us this morning. I'm really interested in following up on what Dr. Mewett was saying around this relationship with palliative care, because we know that palliative care has got a really important role to play in terms of end-of-life treatment for people. And what does that relationship look like with regards to assisted dying and the palliative care world? And a bit more about the multidisciplinary board that you have. I think, Dr. McLaren, you set up. But what does that multidisciplinary approach look like in your jurisdictions?
Dr. McLaren?
Well, I might throw to Dr. Mewett for that first.
The first point Ms. Leadbeater made was about palliative care. There is no doubt that traditionally palliative care has eschewed any idea of voluntary assisted dying. But can I say that's for a number of historical reasons that I won't go into now, and I've spoken about in other fora. But in fact, that's changing, and there's a general change in attitude, especially amongst the younger palliative care training doctors and young clinicians, who, as I said before, see this as part of patient-centred care, honouring the patient's autonomy, choice, etc., while still addressing deeply their concerns and their suffering, their pain management, etc. I think that will see a change. I do understand where it's come from, but I think when one looks at it almost forensically, if you like, it doesn't stack up, and it will not continue to stack up as someone saying, well, VAD is not part of palliative care. VAD is part of patient choice. It'll be part of palliative care ongoing. That will evolve over time. I didn't quite catch the meaning of the multidisciplinary aspect, Ms. Ledbetter. Sorry.
I think was that a board that Dr. McLaren you set up, a multidisciplinary
yes, I can
to look at the safety and the quality of voluntary assisted dying?
Yeah.
Yeah, so this was born out of essentially when we started as a Victorian group. We were very individual, and we interpreted the law in our own ways. We complied with it as best we could, but we didn't have a centralised discussion board or peer group set up at the time. So that's been some advice that we've propagated through the other states to ensure that there are what we call community of practices, where clinicians can discuss their cases and learn from each other. That's been one way. So we several months after, so I think it was from June to November, we had no interconnection with other VAD practicing doctors. In November, we had a forum set up where we were actually able to connect and talk about difficult cases and how we would each interpret those. And then as the subsequent states came online, we were approached by some of the other practitioners from the states saying, we don't really want to reinvent that wheel. Can we join your community of practice? And because that was set up by our state government, they were unable to join. So I saw a gap there in terms of creating a organisation where we could propagate that knowledge and not all start from scratch. So it initially started as a group of voluntary assisted dying medical practitioners, and then we would discuss cases across the board and what would you do under your legislation and under your laws, and we all learnt from all of that. And then we got subsequently approached by pharmacists, by nurses, by other people who are involved in voluntary assisted dying provision, including legislators as well, who wanted to ensure that and contribute to the custodians of the voluntary assisted dying law, which is the people who actually run the projects. So that then led to the creation of Voluntary Assisted Dying Australia and New Zealand. So that's a multidisciplinary group. Predominantly doctors, but we do have nurses, pharmacists, legislators involved. We've had 2 annual conferences where we do discuss issues faced by many of our practitioners, and so that's been a great resource for people, and we are developing standards. So we feel like perhaps in our legislation there was too much in terms of instilling what the standards are. We feel as though the appropriateness of such things like telehealth should be regulated by standards rather than by legislation, which it currently is in Australia. And so these are the types of topics that we like that we have weighed in on and created position statements to help protect the laws that we believe in and we uphold, and we like to think of ourselves as responsible practitioners of.
Thank you. Dr. Shastri-Hurst, please.
Thank you very much, Chair. Can I focus this question to Dr. Fellingham, please? And it's circling back to the issue of training. I wonder if you could go into a little bit more detail about what the initial training consists of, the nature of it, but also the number of hours, how that compares with then the refresher training, and what's the system around mentorship, supervision, appraisal and CPD requirements?
Thank you very much. So I think it's important to reflect that only people who are at quite a significant point through their own specialty careers in this country are eligible to become assisted dying practitioners. So for instance, I was a consultant anaesthetist and I'd already been practicing for over a year. So I'd had lived experience of caring for patients both living and dying, both anticipated and unexpectedly, over a career spanning over 10 years before I came to the point of assisted dying. Then, to become eligible to offer assisted dying, I had to undertake the training, as I mentioned to you, that was developed in a special package by the Queensland University of Technology. That's a training package that spans, it takes about 2 days to complete, and there's an exam at the end before that you can become eligible, and the exam has like a 95% pass rate. Once that you have qualified with that training, you are then offered the opportunity to give your details to the statewide Care Navigator service, and the vast majority of people opt to do that. And once you do that, you basically become engaged in this incredibly supportive, collaborative and nurturing multidisciplinary team professional organisation that in our state covers all of the assisted dying practitioners, all the doctors, but also the care navigators, the pharmacy service, and the individual voluntary assisted dying program managers and end-of-life choices coordinators who exist in all of our hospital systems. Because we're all consultants in our own specialties, there isn't the same level of supervisory oversight, if you like, as we would give to junior doctors. There aren't sort of forms that we fill in, we don't accredit one another. But we acknowledge that we're all learning and growing in this space. These are new laws. Even the oldest in Australia has only been going for 5 years. And every single one of us is motivated from a place of wanting to support and collaborate and grow and learn from one another and ensure that the care that we're offering to people in this challenging space is the absolute highest quality care. So we have a really, really robust community of practice. We meet monthly. Half of those are online to allow our regional practitioners to join, and half of them are face-to-face, and they're extremely well attended, closed sessions where, especially over the time that we've developed relationships with one another, we find an incredibly supportive space to share our experiences and to learn and grow and develop from one another. In terms of CPD, we all have to maintain our professional registration, so I have both general and specialist registration with our supervisory body, like the GMC, and so I complete my mandatory CPD requirements each year as per my specialist college. And then on top of that, I've just redone the refresher training, which is once every 3 years. That's just what was mandated in our state. If you haven't done VAD practice, you have to just do the whole thing again. So that's only for people who've been active in the space. That training is shorter. It's about half a day, but it's really a reflection of what we're doing on a day or a weekly basis. You know, we're living and breathing this work and really strongly collaborating with everybody else who does it as well.
Thank you. Kit Malthouse.
Roger, could you just talk us through eligibility with regard to neurodegenerative diseases and whether there are any variations and considerations that you have in place, things like Parkinson's or MND? And is the main delivery mechanism for VAD in Australia the mainstream health service, or is it delivered through a kind of separate wing or arm of or organisation?
Who is best qualified to answer, please? Any takers?
Greg, I might dob you in for the neurodegenerative perspective, if that's all right. I've been involved in several of those cases, but as a medical oncologist, it's a little outside my field.
What's happened in most Australian states is that a patient with a neurodegenerative disorder, and the most archetypal would be motor neurone disease. Parkinson's, of course, another one. There are a number of other neurodegenerative disorders for which prognosis can be made. The law was actually made so that a patient was eligible if they had a terminal illness of 6 months or less, except in the case of a neurodegenerative disorder, in which case it would be 12 months or less. Now, we've been trying to tease that out as part of our Victorian VAD Review Board work, and we could really not find a logical or consistent reason why there would be two different prognoses for different disorders. We think it was because the legislators or the advisory to the legislators thought that patients with neurodegenerative disorders might lose capacity to continue with the process earlier. But we all know, and the other two my learned colleagues would know, patients with all sorts of diseases can lose their cognitive abilities during their disease, particularly whether it be cancer or motor neurone disease. We don't see that as logical or reasonable, and in fact, one of the things we're considering is recommending that, as Dr. McLaren said before, the prognosis is made as 12 months, which is in fact what Queensland legislated for and practices, that a 12-month prognosis is reasonable for a whole range of reasons.
Thank you very much. I have 3 questions remaining and 5 minutes, so brevity, please. Lewis. No, I'm sorry, we have to move on. Lewis.
Thank you. Can I just be explicit on the palliative care point? So we've heard concerns from some here, I think, within the palliative care provision, that there's anxiety that if we introduce this in the UK, there's a risk of deterioration or failure to improve palliative care. I just wonder if you could just directly address that in light of your experience.
Well, I'll say one thing very briefly. Palliative Care Australia, our peak body, commissioned a report a few years back where they studied the introduction of voluntary assisted dying legislation throughout the world, throughout the jurisdictions. They concluded, and this is a body that was not pro-VAD, they concluded that there was no adverse impact on palliative care services, and indeed often the contrary, that palliative care services were actually strengthened and enhanced because of the emphasis now being placed on more choices at the end of life. So I think that's an absolute furphy, as we say in Australia, a red herring, you might say there, that in fact palliative care services are not in any detriment. And in fact, I would go on to say that this idea that palliative care doctors will leave in their droves if such legislation was introduced is just false. We respect conscientious objection in this space, and we have learnt to live with each other and respect that in this space people are entitled to set their own ethical limits, and we respect that.
Thank you. Very briefly, Surgeon Joseph, please.
Thank you. Could you just let us know if you are aware of any incidents reported related to this, including where the medication administration or misuse of medication, as you earlier explained, patients can take the medication to their home?
Dr. Merritt?
Yeah,
No, Dr. Cameron.
So we were made aware of one situation in Queensland last year where the eligible patient was given the medication. They ended up in hospital and died from their disease, and the husband went home and took the voluntary assisted dying medication and died. This was obviously a tragedy, and no one wants this to occur. And so I don't want to be flippant in talking about it. I hope my comments are taken in the way that they're intended. But we do know that spousal suicides do occur on the death of when people do die. We have had one case across Australia where we have had thousands of successful cases of voluntary assisted dying conduct with no other cases evident. So the rate of that is incredibly low. The voluntary assisted dying team in Queensland, the same day that they became aware of this, put in steps to ensure that it wouldn't happen again, and I believe that was with the return of the the required return of the medication. And I think that we also have to balance the autonomy of having the medication available to patients at 2 a.m. when they have an exacerbation of their pain and say that enough is enough, instead of waiting for business hours when the doctors are available to come and sit with them. So I think it's a very delicate balance, and there will always be that risk. I think the balance is struck well, and I think the safety can be upheld by still providing the patients access to their own medication.
I'm going to take one final comment from Dr. Merritt. We're practically out of time. I'm sorry, there's one member who hasn't been called. But
I'm sorry, just to be absolutely clear, spousal suicide We've had 2 cases, this is prior to VAD, spousal suicide occurs with the leftover palliative care drugs. We've had 2 cases of that in Victoria prior to voluntary assisted dying. So it's hardly surprising that that may occur in a very, very rare number of cases.
Thank you very much indeed.
Really
that has to bring, I'm afraid, this session to a conclusion. Dr. Fellingham, Dr. McLaren, Dr. Mewett, thank you so much for giving up your evening for us. The committee is indebted to you. Thank you very much indeed. Have a good night.
Thank you, Chair. Thank you, Committee.
Bye-bye.
Thank you.
While we're changing over, may I now call the member in charge of the bill to put a formal resolution to the committee?
Thank you, Sir Roger. Unfortunately, one of our witnesses is unable to join us this afternoon. We found out in the early hours of this morning. So I'd like to move a motion that in the list of witnesses set out in the table in the sittings motion agreed by the committee on the 21st of January and amended on the 28th of January, we leave out Professor Jane Monckton-Smith, OBE, and insert Hourglass.
The question is, as has been put to the committee, as many of that in favour say aye.
Aye.
Contrary, no. Motion is agreed. Thank you very much indeed. Who's? Can I just say who is?
For weeks, and we can get through everyone that one and have all.
We're now going to hear oral evidence from Professor Tom Shakespeare from the London School of Hygiene and Tropical Medicine, Dr. Miro Griffiths, who is accompanied by his personal assistant from the University of Leeds, Yogi Amin, who is a partner at Irwin Mitchell, and Chelsea Roff, founder of Eat, Breathe, Thrive. For this session we have until 11:25, and for the record, please, could I ask first Dr. Miro Griffiths to introduce himself and to make a brief opening statement. Thank you.
So, how long do I have for my opening statement? How long do I have for the opening statement?
Very brief, please, to start with, because the committee will be putting questions to you and you'll have, I hope, adequate opportunity to make the points that you wish to make.
Okay. So my name is Dr. Miro Griffiths. I'm based at the University of Leeds. I also hold several advisory positions on disability policy in the UK and across Europe. I'm also connected to organisations such as Not Dead Yet UK. My position is that I'm overwhelmingly against the principles, but also the various clauses set out within the bill, primarily because of my concerns of how it coalesces with the systemic injustices faced by the disabled people's communities in the UK. I also have reservations for how this will affect the relationship between medical practitioners and disabled people's communities. And also, I think there are some deep concerns around issues of coercion and how that's not satisfied within the bill. But I also have reservations for the way in which we are navigating towards emphasising this trajectory of a health service which facilitates and arguably accelerates death over other forms of assistance within the community, but also within our health service.
Chelsea Roff.
Thank you, Chair, and thank you to the committee for having me. Yes, so as the Chair mentioned, I am the director of a charity based in the United States, but working in over 50 countries around the world now for the past 11 years. I'm here in a personal capacity today, and really I'm here as a researcher. My area of research has historically been on treatments and the prevention of eating disorders, but last year it took a turn, and I, along with my co-author, Dr. Catherine Cook-Catone, completed what's called a systematic review, and that was a systematic review of assisted death in eating disorders. And our findings really shocked me. We found that at least 60 people around the world have been euthanized or assisted in suicide. I'm using jurisdiction-specific terminology there. I will use assisted death and assisted dying today. And that includes in 3 jurisdictions in the United States, where I'm from, in Colorado, California, and Oregon. And that's important for the committee because those are jurisdictions where assisted death is legally restricted to terminal conditions. So we saw anorexia listed by name, anorexia nervosa listed by name as a terminal condition, and most alarmingly to me, in 2 of the states, we could not find any mention of documented cases in the annual state reports. So had a physician and her colleagues not written a paper and told the world about it, we would not know that those young women had died. 100% of the cases we reviewed were women. 1/3 were between the ages of 18 and 30. 2/3 were under the age of 40. And I have to emphasize these were young women that did not have failing organs, did not have comorbid terminal conditions. Zero of the cases we reviewed was their organ failure or comorbid conditions, and they had decades of life ahead of them. So I hope that I can be helpful to the committee in sharing the evidence that we've uncovered internationally. I think most relevant, this evidence is most relevant to Clause 2, the definition of terminal illness, and Clause 3, mental capacity, but also relevant to latter stages, parts of the bill on reporting and on the substances, the approved substances used for this process. So thank you.
I'm going to have to urge brevity on everybody this morning because of the length of time we haven't got. Yogi Amin, please.
Morning. Thank you for having me. So I'm Yogi Amin. I'm a partner at Irwin Mitchell Solicitors, where I head up the Public Law and Human Rights Department, and I've worked in the area of mental capacity law and public law for over 20 years, which includes cases where there's disputes over medical treatment and safeguarding aspects. I've put a written note in to the committee this morning. I'm sorry it's late, but it's arrived just before I arrived, so I can touch upon some of the points in there. I should say that the evidence I give and the information I've given is in a personal capacity and should not be attributed to my employment or any organisation I'm in, because I'm also a trustee of the Royal MENCAP Society. And I should also say I'm a Law Society accredited legal representative, which means that as part of my practice, I represent people who are vulnerable, who come before the Court of Protection for decisions about disputes on mental capacity and best interests.
Finally, Professor Shakespeare, please.
Thank you very much for inviting me. As you say, my name is Tom Shakespeare. I'm Professor of Disability Research at London School of Hygiene and Tropical Medicine. I'm a sociologist. I've done considerable research, qualitative research with disabled people. I think I'm here to say that most disabled people support the bill. There are some very vocal people who oppose it, and they have every right to do so, but this bill is supported by disabled people. I think that it's supported because it's restricted to terminal illness, which I think is a very good thing. I think I would oppose the bill, which is actually relevant to all disabled people. This is only relevant to people who are dying already. And it defines terminal illness very clearly. Mental illness, for example, cannot be the sole criterion, so that would rule out people who have eating disorders, I think. I don't think that, obviously we live in a difficult world and there's a lack of social support. I would like to see better palliative care, more hospices and more options for disabled people and people who have terminal illnesses. But I think this should be a tool in the toolbox for people who have terminal illness. They may not select it, but knowing it's there will give them a sort of insurance that they will face death knowing that they have a way out, quicker, better death if they choose that. Most won't, some will, and they should have that right. Thank you.
Thank you very much. Jake Richards was not called during the last session, so Jake Richards, please.
Thank you for those introductory statements. If I made a question for Mr. Amin regarding the current operation of the Mental Capacity Act and how the Court of Protection approaches that issue. obviously the bill as drafted currently essentially defers to the Mental Capacity Act in terms of that, and I just wondered whether you have any reservations about that or any thoughts that you could offer the committee.
So reservations, no. In fact, I wholly recommend and support the idea as drafted to defer to the Mental Capacity Act for capacity assessments. I mean, I've been working in this area for over 20 years, both before and after the Mental Capacity Act came in, and have done cases all the way up to the Supreme Court and day-to-day in cases around the country, and it's well understood how capacity assessments are done, and it's ingrained into the practice of both practitioners generally and legal practitioners in the courts. And certainly when I give training to advocates or to doctors, etc., it is well understood how to apply the test, and that could then just be adapted for this particular decision, which is done here. We've had a decision in Supreme Court in the last couple of years which has settled how to approach the question of capacity, and so really to disturb that would concern me.
Just to be clear, it would concern you because it would cause confusion, or?
Well, it's a well settled and understood approach to the law, and producing a new one would throw up a whole new conundrum where people would be questioning how to approach it, etc. It's not broken, is what I would say, so it works well.
Thank you.
That was a specific question to Mr. Irwin, but it's an important issue. Does anybody else wish to come in particularly? Briefly, please.
Sure.
Thank you.
One thing I'd like to highlight in our study is that all 60 people who died, young women mostly, were found to have mental capacity to make the decision to end their life. So I worry that mental capacity will not be an effective safeguard to prevent people with eating disorders from qualifying under this bill. I would also note Oregon and California, where I'm from and where we've actually found cases, have an additional safeguard to mental capacity. And that is, if there are any indications that the person might have a mental disorder, that person must be referred for a mental health assessment. So it's important not to make a false equivalence between mental capacity and mental health. So we could have a person, for instance, who has 6 months, a 6-month or less prognosis, but their wish to die is emerging from severe depression, from suicidality. And we saw very high rates of suicidality and depression, 89% depressed, and nearly half were chronically suicidal when they died. And that it was, physicians emphasized still that the wish to die was not emerging from a mental illness, despite them having diagnosed mental illness.
Rebecca Paul.
Thank you, Chair. My question is to Chelsea Roff. Firstly, I just want to thank you for your written evidence, which I found extremely helpful. It indicates that in Oregon, California and Colorado, patients with anorexia have qualified as having a terminal illness. There have been instances where patients suffering with anorexia have been described as terminal and treatment withdrawn in the UK itself. Is it accurate in your view to regard these young women as suffering with a terminal illness, and what changes to the bill would you suggest to better protect them?
Thank you for that question. No, I do not think it's accurate, but I have to emphasize that laws in other countries have expanded through clinical interpretation, not just legislative amendments. So there are clinicians, a very small minority, who disagree and have characterized anorexia by name as a terminal illness, but they have also said that eating disorders qualify because of the physical manifestation of the disorder. You can't disentangle a mental disorder from its physical effects. So they cite terminal malnutrition. We've identified 25 cases between California and Colorado where malnutrition was listed as the terminal condition. I can't rule out if that was anorexia or something like voluntary stopping of eating and drinking, but I worry that it's the physical manifestations that will be cited, and without a mental health safeguard in this bill, that puts a whole lot of people at risk.
Thank you. Dr. Griffiths or Professor Shakespeare, do either of you wish to comment, as you haven't spoken yet?
I would say that if you look at Section 2, the definition of terminal illness is very clear. The person not to be considered to be terminally ill by reason of having one or both either a mental disorder or a disability. So I think that would cover that case.
May I, Chair? Just one sentence. I think you've left out an operative word in that sentence, which is only. So a person is not considered by terminally ill by reason only.
Thank you. Mary Tidwell.
And just to clarify, that word is in subsection 3. So just for Professor Tom Shakespeare to start with, and then if I may, I want to follow up with Dr. Miro Griffiths. Tom, why is it so important that disabled people have a choice? I made it very clear when I voted at the second reading that I would only do so because this bill was not about intolerable suffering, but was limited to 6 months terminality. So can you just expand on that point, please? And any research that's been done in jurisdictions where equivalent legislation is now in place from the perspective of disabled people, please?
I would say that it's very important that it's for terminal illness only, that should give a sense of safety to disabled people. There are, in jurisdictions like Oregon and California and Montana that Chelsea's mentioned, we have not had an extension, not had an expansion from terminal illness to, as it were, suffering. If you don't carry suffering in the bill, you will not get, I think, into the situation that Canada got into. I gave evidence because Canada was seeking, some people were seeking to expand the coverage of that act to all disabled people. And they did so by referring to the Canadian Charter of Rights and Freedoms and to the word suffering. And they said, look, lots of people are suffering, not just terminally ill people. And therefore it's very important that it's only terminally ill people who are covered by this bill. And that, as I say, should give disabled people some support. We talk about choice and control, as you know, Marie, as being the principles of independent living. Disabled people should have rights over their lives. And this is people who are disabled, yes, but terminally ill primarily, and that's why they should have this law, which gives them choice and control over their lives. They're going to die anyway, but it removes the fear of and the reality of a difficult and unpleasant and undignified death.
Thank you. Dr. Griffiths, do you wish to add to that?
Please, yeah. I think this issue highlights a fundamental flaw with the bill, which is this nonsensical division between a terminal illness and what constitutes being a disabled person. We are aware in the clause 6 of the Equality Act states a disabled person is somebody who has a physical and mental impairment, and an impairment which has a substantial and long-term adverse effect on their ability to carry out day-to-day activities. Now, of course, if you have a terminal illness, it is likely that you will be defined within those terms of what's outlined in clause 6. So it's a fundamental flaw, because disabled people will be incorporated within this. It also highlights this arbitrary nonsense around a 6-month perspective. What constitutes 6 months left to live, particularly if you are engaging with technological devices, with medical assistance and so on. For example, for myself, with a progressive condition which continuously gets weaker and has respiratory complications and so on. If I remove my ventilator, which I use at night, if I remove my medical devices and my engagement with therapeutic services, does that constitute then that I will have a terminal illness? Because my rapid acceleration towards death becomes more evident. So I think that these concerns and these issues highlight fundamental flaws, but they also play into what I think is a key issue, which is the continuation then of campaigning that will continue after, if the bill is to succeed, because then you will get people who will say, well, why not 5 months? Why not 7 months? Why not other conditions that are not being highlighted in our current discourses?
Sarah Olney.
Thank you, Chair. Dr. Griffiths, do you think it is possible that disabled people are likely or potentially more at risk of being coerced or otherwise persuaded to seek assisted dying as a result of this bill?
One, because I think the coercion principles outlined in the bill are incredibly weak in terms of the scrutinising and also the process of how you judge whether coercion has taken place. We know coercion is a complex issue, and when you then contextualise that in the context of disabled people's lives, we talk about disabled people who are struggling in the day-to-day access to sufficient support, struggling to live in participatory and accessible societies, the feeling of then societal coercion to feel that this is a tolerable idea, I think highlights the concerns I have about coercion. But also it plays into this issue around support and assistance to understand what your rights are, not just in terms of what we're talking about here, but broader disabled people's rights. There's a lack of advocacy services available to disabled people. There is a lack of support for disabled people to have accessible information about their rights. So if you feel that assisted dying is your only choice, as opposed to accessing support, accessing and calling out discriminatory practices within, say, access to social care, access to healthcare and so on. This again highlights issues where coercion will manifest, and the infrastructure to support people either to respond to coercion or understand that you don't have to be in that position in the first place is non-existent.
Thank you very much. Sorry, Tom Gordon, please.
One of the things that we've heard from other countries where they have assisted dying is that this is actually one of the strongest and most robust laws. I'm just wondering if Professor Shakespeare, if you had any further views on how we could make it even tighter and provide support and sort of further sort of peace of mind to people who might be worried about this.
When I read the bill, I thought that it did have many safeguards. It has, for example, 5 opportunities for a conversation with doctors or other supporters. So I think that is a good safeguard. I think it makes a criminal offence of dishonesty, coercion or pressure. So I think that will scare off people. And Miro is quite right. There are people who might put influence on somebody. But I hope that they would be covered under Clause 26 as having committed an offence, and that would scare people who may have a particular view against assisted dying. How could we make it stronger? I think maybe having more of an advocate for the person who is requesting assisted dying, somebody who will support them within the law to make that decision or to think about that decision. We're trying to make sure that everybody who is thinking this is for them has the opportunity to talk about it and to think about it. And the time and the conversations are all about that. But maybe an advocate also would be the person who is requesting this death who is not beneficiary in any way of that death, could be a neutral party to give advice. I'm not sure. But there's a lot here. There's 5 conversations. So I think I'm not surprised that people thought it was strong. I think it is a strong act. There is a scope for doctors and other medical practitioners to to act on their conscience and to withdraw from this. I think that Miro may make a useful point that we do not want any disabled person frightened of their doctor or worried that their doctor, who has been supporting somebody else to die, might do that with them. I wonder whether, I think in conversation with Marie, we've talked about a assisted dying service as being a part of the NHS, but specifically around this. I think that's worth considering. Whether your average doctor is the person to whom you should take a concern or a wish to die. So advocacy and maybe having a specific service for people who want to go down that route. But I think it's a strong bill as it stands.
I think just adding on that as well, one of the things that we've heard from other people and other jurisdictions is moving away from a High Court judge and having a multidisciplinary team and panel. Yeah. Is that something that you think would further strengthen it, and would you support that? I think
law is only one of the influences that might be there. There's also physical health, mental health, and also social well-being. So I think a multidisciplinary panel might be a better way of finding out. But I bow to my friend who's got a lot more experience of legal panels than I have.
Mr. Amin, do you want to comment?
Well, the way it's drafted, the judges reviewing the case are not making an order, they're declaring a plan that someone else has produced and put in front of him. So it's a strong independent legal judicial safeguard as part of the bill, so I understand that. And my written submission will, you'll note, says that the courts are well used to doing this. The courts have been doing it for many years. They've been dealing with disputes over facts, disputes over capacity, disputes over medical treatment issues. They're able to identify safeguarding issues. So the courts and the judges are certainly able to do it. I'm not speaking to the question of capacity. And if the question is, do you introduce something different from the High Court, then I'll certainly wait to see it and scrutinise it. But as it's drafted at the moment, I would say the High Court judge is a strong legal safeguard as part of the mix of safeguards in the bill.
I'll come back to Marie Tidball again, but can I make it plain to the panel that while questions are being directed specifically to panellists, if anybody wishes to come in on something, do please indicate. Chelsea.
Just to your question, Mr. Gordon, around is this the safest bill in the world? I know there has been due care taken to make that happen. One of my biggest concerns with Clause 2 of this bill is that it makes no distinction between a person whose illness can become terminal if they refuse or cannot access treatment. For instance, someone with diabetes. Type 1 diabetes affects 300,000 people in this country, often co-occurs with eating disorders, and the way this is written would not prevent someone who chooses to stop taking insulin from qualifying as terminal. I will also, last thing, add that in the US we are seeing voluntary stopping of eating and drinking used to circumvent the terminal illness safeguard. I'm going to quote the American Clinicians Academy on MAID, which is the professional body. Legally, there is nothing in the letter of the law that explicitly prohibits voluntary stopping of eating and drinking as a terminal diagnosis to qualify for assisted dying. They describe this as a legal gray zone that would essentially eliminate the terminal illness criteria. There is nothing in this bill as written that would prevent that. And you have to look at the letter of the bill because it expands their interpretation, not just amendments. Thank you.
Final question, Marie Tidball.
Thank you. And this is directed to Professor Tom Shakespeare and Dr. Miro Griffiths. And one of the amendments I'm backing would establish an advisory council on the impact of the bill on disabled people, because I'm passionate that we monitor the impact, should this pass through Parliament, on that group of people. And I just wondered if you can both reflect on what structure or mechanism you think could work to facilitate this.
So I think this plays into a broader issue around the reporting mechanisms associated with the bill. And I think there needs to be further robust action around how to collect data, how to allow it to be analysed, and then how it allow it to see the trends that are occurring in terms of possibilities of why people may be pursuing this option, but also how that may play into broader political, socio-economic issues, such as a lack of services elsewhere or frustrations with disabled people and their families trying to access particular services. I would encourage that if any advisory council was created, and I think this goes back to a point that was made by Tom, is that you would, whilst we may see popular opinion within disabled people's communities, it is of worthy note that there is no deaf and disabled people's organisation. So these are organisations that are representative of disabled people who engage critically with the issues facing disabled people's communities. None have been in support of this. So therefore I would encourage to have their representation and within any form of advisory council. And I would also request that scholars such as disability studies scholars that are often left out of the discourses around disability policy are also part of any form of mechanism to advise or to scrutinise.
Professor Shakespeare.
Yeah, I think the council is a very good idea. I think it should reflect the range of views, absolutely, as Miro says. What is relevant to me, I think, is that in Oregon, disabled rights advocates have not, as I understand it, opposed the bill that they now have, that act that they have, that disability groups are of course they're mixed, but some are definitely in favour. So I think there is a difference between organisations of disabled people and disabled people on this. And certainly that seems to be, so politically, the disability rights community against assisted dying, they always have been. That does not mean that they reflect what ordinary disabled people want. And that's what is important, I think. I think you should be interested in what people want, and they want this.
Sean Woodcock.
Thank you, Jen. My question is to Dr. Griffiths and Chelsea, if I may. We've had 2 days almost of evidence. Yesterday afternoon we had practitioners from the States. This morning we had practitioners from Australia. And the message seemed to be very clear that coercion essentially doesn't happen in voluntary assisted dying. That was the very clear message that they gave. And the message also was that those who went through it were people who wanted to, and it was very appropriate for them, and that there was almost no issues. Can you explain why they're wrong, if you believe that they are?
Well, going back to my previous point around how coercion can manifest in various different ways, and one can be exposed to the societal pressure to feel that your life is no longer tolerable because of the struggles that you have in terms of accessing services, accessing provision, accessing support. We know from data that we have people in the community who are struggling to see their GPs, who are struggling to see their consultants associated with their conditions and changes in their condition. So the coercion, I feel, will come from how society is organised and does not respond to the injustices faced by disabled people. But I also think there's a broad and slightly different issue as well, which is there's nothing in the bill, in my view, that satisfies the concern that when you have, if it was to pass, you would create a network of practitioners who are sympathetic to the principles of assisted dying, and therefore will understand that when somebody comes forward to say, I want to die, that they will be more they will be more receptive to those ideas that the individual has, and therefore will facilitate their process through this, which I think undermines then any attempts to have objective scrutiny of coercion that may occur. There's nothing that stops you from saying, well, I know that there are these certain people I can go to who have either been public or have supported others to have access to the service, and therefore that's my best chance of gaining access. And I think that then collapses all attempts to address issues of coercion.
Thank you for your question. I would add to what Miro is saying to say that what we've seen in our study is a more subtle form of influence, and sometimes it actually comes tragically from the clinicians themselves. We saw 95% of clinicians tell the patient and their family that they had an incurable, irremediable illness with a 6-month or less prognosis in some cases. And that has an influence on a person. And I have to say that does not cohere with the evidence on eating disorder recovery. In fact, we have no good ways of making prognosis in eating disorders. The only good prognostic indicator we have is weight restoration. I would also highlight, relevant to here where we live, that the APPG just put out a brilliant report on huge gaps in the care system. I'm working with a person and a family right now who's been to the Court of Protection, whose eating disorder team presented her and used the term not treatable to the judge, and used the term in the end stage of her illness, and predicted that she would die within 6 months. 18 months later, she and her family are still fighting for treatment and are being denied services. So that is the kind of coercion I'm worried about, is the kind of coercion that happens within a healthcare system that I know many of you were elected to fix. You know, that's what so many people have called for, is fixing a broken NHS. And that's not my choice in terminology. I love the NHS, but I think that's what we need to be worried about, is especially in Clause 4, subsection 4, That to me reads like a formula for coercion. If a physician were to say to a young woman with an eating disorder, you have a severe and enduring eating disorder, which you will not find in any diagnostic text, but is used frequently in these cases and in the court of protection. We have done all we can. The treatment options are exhausted. Again, you will find that in the court of protection. Your prognosis is poor. It leaves you with a feeling that you have nothing left to choose from, especially if you're struggling to access services.
Thank you. I mean, no discourtesy to the committee, but we have 10 minutes, 20 minutes, and 10 members wishing to ask questions. So we have to move this on, I'm afraid. Rachel Hopkins.
Thank you, Chair. Can I ask Mr. Amin about his views on coercion, particularly in light of Clause 2 in reference to the Mental Health Act and the Mental Capacity Act, and any thoughts you have, particularly on the groups you represent, about that?
Well, as I said, I've worked in this area for over 20 years. I represent individuals week to week in this area, and safeguarding is all across what's needed for these individuals. And when you're talking about professionals who are involved in their lives, they're regulated. So we're talking about doctors here who are meeting individuals, and they understand what it means to identify safeguarding triggers and where referrals are required. So I think that makes it quite strong in this particular Act. The wording, as you've got it in the Act, I'm comfortable with. And I say that as someone who's worked in the area for many years, and lawyers will go to court and pick over words, but I think the way it's drafted, it's understood that there is voluntariliness as described within the bill, and coercion. I don't think additional words are necessary to describe what's required here. It's a voluntary free will decision, and coercion's defined there. So when we're talking about a doctor trying to understand that and a court then interpreting it, I think it's pretty clear what that is. So I'm comfortable with the way it's drafted. Generally, on a safeguarding perspective, as Tom has said, there's a number of points at which professionals are asking the individual for the decision here over a number of weeks, goes into months. So it's quite a robust process here. And I point also to my note, footnote 3, paragraph 4 of my note, where I've referred to the current existing law outside of the Court of Protection, where it might be thought that the person has capacity, but there's concerns about coercion, etc. There is, under Section 42 of the Care Act, the provision for safeguarding referrals. There is, under Section 222 of the Local Government Act, provision for a local authority where referrals are made to bring the matter before the court under the inherent jurisdiction. And the inherent jurisdiction doesn't go away. It's here and available where there are concerns for safeguarding of an individual to allow them to make their own individual free will decision. It's not there to do anything other than protect the individual and have a safety net around that individual to make individual autonomous decisions. So I think nothing needs to be tinkered with, I would say, in the current Act, because that is there. Parliament's already provided for that. Have I answered your question?
You've given clarity, thank you.
Thank you. Julian Campbell, please.
My question is to Professor Shakespeare and to Dr. Griffiths. In Section 4 of the bill, it offers the opportunity for clinicians to be the people who instigate the discussion on assisted dying. Could you both tell me your view on that, please?
Thank you. Professor Shakespeare.
I think that it's natural and right that somebody should discuss their wishes with the doctor who supports them and treats them. I don't think there's a problem there. I think Marie, her suggestion that there should be a wider body to look at this is very relevant. And I also think that doctors at the moment refer people for abortion, women for abortion. And that does not stop them also supporting pregnant women. And no, I don't think women would, distrust their doctor because they're sometimes involved at some point with the abortion decision. I think it's quite obvious, and it's, as my colleague said, in the bill, what is a terminal illness and why we should support you voluntarily to exercise your choices. And I think, lots of doctors will not be in favour of this. I think they will be clinically professional. They will discuss with the person. I don't have a concern about that. I think you're more likely to be kept alive against your will than you are to end your life under this Act.
Sorry, Chair.
Dr. Griffiths.
So I think my first point would be it raises concerns because it relies then on doctors' interpretation of prognosis. So if a doctor assumes that you have 6 months left to live and is therefore then going to start having a conversation with you about the possibility of suicide, I think that then draws into question how we are allowing then this assumption made about if an individual does have 6 months left to live, and particularly when we have evidence that shows that with certain interventions and also certain mishaps surrounding prognosis, individuals can live for months and for years and decades longer as well. So the idea of bringing in the conversation from the point of view of the medical practitioner could arguably accelerate one's death. If the idea of prognosis was taken into account, that their idea of prognosis may be flawed. It also, I think, raises problems because we know that many individuals, and whether we want to create this false line between disabled people and people with terminal illness, irrespective, individuals with health conditions and impairments do not have access to advocacy, do not have access to a representation in processes such, for example, in this kind of process. So therefore, having a conversation where there is extreme credibility and validity that rests on the medical practitioner could, I think, exacerbate issues around coercion as well. But also, I would just like to add as well, for me, I think we could take a moment of reflection. For example, when we were going through the pandemic, the Parliamentary Health and Social, the Parliamentary Ombudsman for Health Services highlighted how the interpretation of medical practitioners to think about the use of do not attempt resuscitation orders and how that was utilised within the disabled people's community, I think has parallels with the issue we have here where medical practitioners will be making assumptions about whether conversations or applications should be made.
Thank you.
Can I just raise one point on representation, just following on, is just point members to paragraph 10 of my written submissions, which tries to make the important point that if we're involving courts, individuals need access to justice, they need access to advice, and that means legal aid. And so I point in that paragraph to the provision for non-means tested legal aid, just like parents of children where withdrawal of life-sustaining treatment. Those current rules are in place for parents, and a similar arrangement could be put in place for individuals who are brought before the court in this matter.
Liz Saville-Roberts.
Question for Mr. Amin, because we have England and Wales as a single jurisdiction, but health's devolved, and we have been discussing an amendment, it appears likely, to Clause 12 in relation to the court of a multidisciplinary eligibility, something or other, as opposed to a high court. What are the implications for us to understand as a committee in how this plays out with health being devolved, but the jurisdiction being single?
Mr. Amin?
When we're talking about a legal panel, I mean, if the legal panel is not a High Court judge, but it is a multidisciplinary panel, then it just draws upon the people in the local areas. So when it comes to the Court of Protection, that operates in England and Wales, and the judges apply the law the same way, and that's what the panel would do in this case. Are you more concerned about the makeup of the panel or how they apply it?
What I'm trying to tease out is what is the responsibility of the Senedd and what is the responsibility of the UK government, because this is going to be challenging given that health is devolved and has been for 25 years.
The responsibility are you talking about responsibility for resourcing it, or
who has to decide who is appointed to what, which body?
Oh, I see. Well, I suppose if there is a multidisciplinary panel, then the judiciary would appoint the individuals going there, and the they would it would be a judicial body, essentially. I don't know if you're talking about a tribunal that's multidisciplinary, although I know people shy away from tribunals.
I think there is a question, because we are a private members committee, as to how we ascertain these details. But thank you.
I think that is a matter that we may have to pursue elsewhere. Nasha.
Thank you, Chair. I have a quick question for Dr. Griffin, and then if I can move to Chelsea. Dr. Griffith, how does the bill exasperate issues for disabled women in particular who might be experiencing abuse or other vulnerabilities?
Well, there's no indication of how you would place the infrastructure for support for people who may be having whose discrimination or their exacerbation of injustice exacerbated through an intersectional lens. For example, the cross-cutting of different experiences, how that can be attested for within the bill. So, for example, there is no infrastructure for if an individual comes forward to discuss with their doctor about the concerns that they have, how that will be acknowledged from an intersectional critique. I think there's also concerns here about the way in which we know that many people within disabled people's communities from particular backgrounds, such as women, for example, are pre-exposed to further levels of injustice that are not accounted for, and that their experiences of trying to access support or trying to access support for certain aspects of their life are compounded by inequalities, and therefore these issues aren't addressed by the bill. And what you will have, in my view, is that you will have individuals who will, if this mechanism becomes available, the issues that they face in terms of injustice will play into the consciousness of their decisions to go forward with this. And I can't understand any clause or any amendment that would address that issue in its totality.
Thank you very much, Dr. Griffiths. Just before I move on to Chelsea, just to point out that Professor Shakespeare, you've said that most organisations support this, disabled people support this bill, but actually only one organisation, one DDPO, has opposed it, is giving evidence. So I just wanted that point noted for the evidence in particular. Chelsea, coming back to yourself, thank you for your evidence. Eating disorders are classified as mental disorders under the Mental Health Act, and this bill explicitly states a person cannot be considered terminally ill only because of a mental disorder. You've also talked about the withdrawal of insulin. Could you respond to both of these? Why do you believe eating disorders would still meet the criteria under this bill, and the issue of insulin, stopping insulin in particular?
Ms. Roff?
Yes, thank you. I would draw and underline, there's a false distinction being made between a mental disorder and its somatic or its physical manifestations in this bill. Mental disorders, especially eating disorders, not just anorexia, impact the body, and they have life-threatening consequences. We had 20,000 acute hospitalizations for eating disorders in this country last year, and we have, again, massive gaps in care. And those are individuals who, if they were to choose to forego treatment, would qualify under this bill or could not access treatment because they're on wait lists for a long period of time. I would draw your attention to the evidence I submitted with Dr. Agnes Ayton, who's at the Royal College of Psychiatrists, Dr. Angela Garda, a leading physician from Johns Hopkins University, and I would also draw you to our own case law, the Court of Protection, where we've had physicians represent eating disorders as terminal conditions, as in the end stage of their illness. And then I'm grateful that you've drawn the connection to diabetes, because it's not just about eating disorders. Substance use disorders would have this same effect, and outside of mental disorders, HIV/AIDS is a progressive condition that cannot be reversed by treatment. Are you okay with a 19-year-old young man who decides to discontinue treatment qualifying under this bill? Those are the questions you have to ask. I'm not in principle against this bill, but you have to look at the letters on the page because they will be interpreted after the bill is passed and your constituents are depending on you.
I'm sorry, we still have more members and more questions than we have time, so I'm going to come down to one question per member. Kim Leadbeater, please.
Thank you, Chair. Thank you for coming and giving evidence this morning. It's incredibly helpful. I'm going to come back to Clause 2 of the bill, the definition of terminal illness, because I'm very clear who this bill is aimed to help, and who it is not aimed to involve. So the definition says that the person has to have an inevitably progressive illness, disease or medical condition which cannot be reversed by treatment. It also says, for the avoidance of doubt, this cannot be a mental disorder or a disability. So what I'm really keen to know is, because I hear your concerns and I want to support you and work with you on this, what else do you want to see in the bill that would reassure you that this is not about disabled people and it's not about people with mental disorders?
Well, I'm conscious of time, so I'll be very quick. But I suppose my first point would be, why would you stick it at 6 months then? Why not have it at 7 days, for example, as a way to take out the issue concern that we have? Because we're talking about, if you're talking about prognosis, going back to Chelsea's point, going back to the point that I made before, our condition, my condition is a neuromuscular condition. I have had meetings with clinicians where some have referred to it as a terminal illness, some have referred to it as a life-limiting condition, others have referred to it as a progressive condition. So the articulation of the ideas and the ways in which we think about conditions, again, I think shows the complexity that we are talking about disabled people, and terminal illness and people who are terminally ill do constitute as disabled people under the clauses of the Equality Act. So you cannot make the distinction. And for me, I think if you wanted to be quite proactive about it, then why not reduce the prognosis time frame to make it as short as possible, to take out the concerns around prognosis, to take out the concerns around if individuals are going to live longer, or they could be facilitated access to alternative treatments to prolong life. I don't understand why we are fixated on the 6 month prognosis, because, and again, what we've seen in other countries is as soon as you pass it on 6 months, you will have individuals who would say, why not 7 months? Why not 5 months? And then you'll have campaigners who will say, this doesn't include me and I've been campaigning for this. So there will be a pressure to change. And governments will change. So there's no guarantee that you can make that the eligibility criteria will be fixated.
Danny Kruger.
Thank you. I just wanted to give Professor Shakespeare the chance to respond to the point that we've heard. I'm just interested, Professor, if you recognise that many disabled people would qualify as terminally ill under the terms of the bill, and what protections we could give to prevent that. And in fact, not just disabled people, but anybody who declines treatment that keeps them alive.
Well, thank you very much. Thank you, Chair. First of all, I mean, the terminal illness is defined as a condition which cannot be reversed by treatment. And I know that that isn't a cure. You're not aiming at a cure, but it cannot be reversed. So surely that would include things like HIV and diabetes, because they can be reversed. They cannot be cured. They're still there, but they can be reversed. You've got insulin or antiretrovirals or whatever. I think, yes, terminally ill people are disabled people almost always, but that doesn't mean that all disabled people are terminally ill. And even if you have a disease or a condition like Miro or like other people, which will probably result in your death, eventually you're not going to die tomorrow or in 6 months. You may die in 16 years or whatever. And I think it's very difficult to define terminal illness. And that's why 6 months, I think, is used in the Act. If it was a week, I mean, how many... I remember very recently, my aunt died. She was unconscious for the last month or so of having cancer, and then she finally died. She would not be able to express her will and her preference to have assisted dying, even if she wanted it. Therefore, I think 6 months, when you can be in, you can have capacity, you can anticipate, you know you're going to die, but you want to have control of the manner of your death. I think that is more useful than a 7-day or less when you might be unconscious and you might not be able to express a will or preference about it.
Simon Ofer.
Actually, my question has been asked by the honourable member.
Sure. May I respond briefly?
Briefly, please.
Thank you. I want to address your question, and I know it's not your intention for eating disorders to be included in this bill, and I'm grateful for that. When I started our research, I thought we just need stronger safeguards. That was where I began. And after looking at 33 jurisdictions around the world, I have real doubt about whether safeguards, I know how difficult it is to put it on the page and I'm seeing it expand and be applied through interpretation. I would disagree respectfully that diabetes is a reversible condition. You cannot go back in time and reverse that condition. And I would also just really emphasize to all of you on the committee that the question before you, you are doing this for a noble purpose. I agree, and I have members of my family that want this to go through. And yet the question before you is, could this bill have knock-on effects that affect some of your most vulnerable constituents? And how many deaths are you okay with? That's really, if the safeguards fail once, that is a human being who maybe in a despairing moment was handed a lethal medication instead of the care and the treatment and the health they need. That's what we're talking about. So you really have to get this right, because those people are depending on you.
Lewis Atkinson.
Thank you. Can I ask Mr. Amin, in particular, for your view, given your expertise in representing these cases towards the court, around particularly the mental capacity issue, Mental Capacity Act issue regarding eating disorders and other disorders? Obviously, we've heard one version of that. In terms of your experience of working with UK law to the highest level, what your assessment of that is?
Yeah. I mean, I have worked in a range of medical treatment cases over many years, so different illnesses and conditions, and Section 2 to me reads fine. It works. It's clear. I don't consider it needs any additional words, and I can understand when we go to court, cases will come through and they'll fall within those definitions, and it'll be clear. From anorexia, I mean, I don't consider it to be coming into a terminal illness unless it's right at the end of life, and that doesn't really fit within the parameters of this Act, because we're not talking right at the end of life. And then you've got the Mental Health Act, Section 63, that deals with anorexia, where there's force feeding that clinicians consider. So, I mean, that's my view on the anorexia side of things. And I think doctors will provide the evidence on terminal illness. And you've heard from the Chief Medical Officer yesterday, and they're going to provide guidance around all of that. And subsequent to this Act, there'll be the secondary legislation and then the guidance. And they will provide that clear guidance, which will then feed into this, and the evidence that will be before a judge that says, yes, it is a terminal illness and the prognosis, etc. So it's nothing different to what we produce in medical treatment cases before the court at the moment, where the doctors produce expert reports and give evidence, explain the condition, explain the prognosis, explain their decision on capacity, and explain what's in the best interest of an individual if they lack capacity. That's, as I understand it, how the Act is crafted to produce the evidence as you go along the path here and then eventually to the judge.
If I made just one sentence, because it's related to eating disorders, I would refer to a 2012 Court of Protection case where a 29-year-old with anorexia was described as in the terminal stage of her illness, where the physicians, multiple physicians, described her death as inevitable. And I would also refer to a 2023 case seen at the Court of Protection where a young woman, where it said, I recognize with deep regret that it will probably mean that she will die, and she was described at pre-death stage. And that young woman, again, is still alive and still fighting for services. So while I respect what you're saying and I agree with your interpretation, we have case law in the UK where people with anorexia are being found to be terminal. So we've got to take that reality into account.
I don't think they were found to be terminal, but they were described by a doctor in a case that they were terminal, and that doctor may not have described it properly.
Indeed, but a judge will be
Thank you.
Thank you.
This will have to be the last question. Jack Abbott, please.
Thank you, Chair. My question for Mr. Amin. You worked on the judicial review of Noel Conway in 2018, and for the committee's benefit and those watching, Mr. Conway had terminal motor neuron disease, and he looked to bring a judicial review in order to have the option of assisted death when he was in the final 6 months of his life. Mr. Amin, what were your kind of experiences from that case which may inform our learnings as part of the committee when we're looking at the bill?
Well, Mr. Conway was an extremely intelligent, brave individual who campaigned in this area, and his strong view about autonomy has brought him to bring that case, and what he was arguing for in that case forms part of what you've got here in the bill. So he was certainly asking for a process where a decision can be made and some robust safeguards can be provided, so that which would end up with a court process, and that's what you've got within this bill. I've also learned through that case and through other cases over the years what the Human Rights Act means here and what the European Convention means here, and parliamentary sovereignty. So on all three counts, the cases have always said that it's Parliament that makes the decision, so it's you that's deciding. I don't see a court overturning that, and the courts in the Conway case, both High Court, Court of Appeal and Supreme Court, were all very clear that it's a matter for Parliament. I really don't see European Court of Human Rights overturning in any way at all, and that's my long experience. The margin of appreciation is very strong with this Parliament to make the decision. And I also think from a drafting perspective, what the bill does is very carefully define the individuals. It's drawn the line. And certainly the courts cannot do it. The courts cannot extend that line. The courts will always defer back here to Parliament. So if you craft this Act as it is,
Order.
Very confident that it will be.
I'm terribly sorry,
here.
we're out of time. Off the record, because I think we're now off the record. Yes, please.